And welcome. I'm Dr. Deuk. Let's inject. We are streaming live spine surgery from Deuk Spine Institute, Surgery Center, Vieira. Our patient here, actually, I should say he comes from Korea because he spent 40 years in Korea, and he injured his cervical spine or neck. He has pain in the neck, like many patients do, and as a result of what's called facet joint pain. Facet joints are small joints on the back side of the neck or spine, and our patient is asleep. We're going to be performing a procedure called a rhizotomy, and we do it a certain way called the Deuk plasma rhizotomy. And what's different about our way versus other ways is our way, unlike the more traditional radiofrequency ablation, which doesn't work and doesn't last when it does work. The radiofrequency ablation, unfortunately, doesn't use the right technique to destroy the pain nerves, but our technique does. And we developed here at Deuk Spine Institute. We've been performing it now for almost 3 years, maybe even more than 3 years, I don't know. We have to look back at the first patient. I still remember her. Do you remember? No. It was a lumbar. Anyway, so he's here to basically get rid of neck pain, and we're going to help him do that. He's got a bad disc at C5-6, is it, guys? So we're going to do that next, but right now we're working on his facet. Shot? I'm trying to make my way, and I'm almost there, to the place that I have to destroy the pain nerve. And folks, that place is the lateral border of the facet joint, which I'm almost there. I just need to go a little bit further. Shot? It's the lateral border of the lateral mass, it's called. The lateral mass is a part of your spine where, and he, by the way, show us where the lateral mass is, Jordan, for the audience. Yeah, that's the lateral mass. Jordan has the center of the lateral mass. Shot? I need to get off to the side, which I'm making my way there. Show us the amount of arthritis. This man has more arthritis than I've seen in most. Shot? That's right. Tremendous arthritis. All right. I'm literally in the perfect spot. I just need to get deep enough, which I am not, because I think it's either his skin. I need a little more visibility here, more light. Help us out with light, Dr. B.
Sure.
Come from the side. I need you to illuminate my finger.
Right here, Dr. B. Right here.
Okay.
Right here.
Oh, sorry.
I cannot see. Give me a knife. I think I have to make the incision a little bit bigger.
Yes, sir.
Yeah, that's the problem.
You want to bring that other one?
Oh, stop moving it. I got to see from here. That light will not. Other light will not work. It's got to be yours. All right. Take. Let's see if that's better. Shot. All right. Shot. Any questions, Henry?
At this moment, no current questions.
All right, let's show the audience how is it a facet joint can be so painful. All right, our video has shown you how pain comes from a facet joint, And now let's show you how we get rid of pain from a facet joint. Henry, you have our Deuk plasma rhizotomy video.
Of course.
Facet joint injury is a common cause of chronic neck pain. The inflamed facet capsule tear generates pain signals. The best treatment for facet joint pain is the Deuk plasma rhizotomy. The inflamed facet joint pain nerves are destroyed. The advantages with the Deuk plasma rhizotomy is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back. We are still working on getting down to the spine. As expected, the back of the neck is quite thick. There, I think we finally are there. Shot. And to do this procedure, as you saw in the video, you have to be on the bone. Shot. Shot. And that's what's taken a long time. If you don't burn in the right spot, you're not going to get rid of the pain. So getting to the right spot is everything. And that right spot is, let's take a look. That's perfect. That is the right spot. And I can tell you there's a massive amount of scar tissue from that arthritis that I was pointing out earlier. That scar tissue is pushing my probe away. So I'm on to the second site. Man, ton of scar tissue. Let's just see. Shot. Okay. Shot. Good. When I say shot, folks, what I'm asking for is a picture from the X-ray tech, Jordan. I'm prescribing an X-ray picture. And that X-ray is what guides me to get to the area I need to get rid of his pain. Shot. Shot. We call this image guidance. In other words, you used to seeing surgery done where the surgeon can see inside the patient with their eye and they make a big cut. But when you're doing less invasive treatment, we use image guidance. I'm almost done with my side, the left. Image guidance in this case is an X-ray machine. That's what the picture is you're seeing, right, Henry? The
Yes, sir.
audience can see the X-ray.
Of course.
Yeah. Give me a second, Luis. We're not ready yet. Shot. Okay, to medial. Want to be a little bit more lateral. Shot. That's too lateral. Want to be a little bit more medial. See how it's so easy to be off when you're using small holes in the skin and you're doing what's called percutaneous surgery. It's really easy to not be in the right place. So you always have to check with something that allows visualization. In this case, the X-ray machine. Shot? Yep, that's perfect right there. So now that I'm in the perfect spot, I'll do my burn. Okay. And we call this the Deuk plasma rhizotomy. This technique was actually developed here at Deuk Spine because so many patients had RFA and the pain just kept coming back. RFAs don't really cure pain. They just temporarily reduce pain from facets, but to get a cure, you have to permanently destroy the pain nerve, and that's not easy to do. You certainly cannot do it with an RFA. Shot? So we developed a new technology, and that new technology uses several different new aspects or attributes that were not present with RFA. One, much higher energy is being delivered in the form of plasma, which is energized electrons in a gas. And second of all, shot, we are doing something called wanding, which is, you can't do it with an RFA. With wanding, you actually move the device tip around to make sure you get the pain nerve. See, that's one of the reasons RFA fails, is you don't move the tip left, right, up, down, side to side. You just stick it in there and pray that you get the nerve. But it never works. And unfortunately, people stay in pain and they end up having to repeat the procedure over and over and over again. Whereas with ours, we have to repeat this rarely because it works the first time. And the only reason it doesn't work is if there's basically surgeon error. You know, we just technically didn't get to where all the nerve is, the bad nerve, the pain nerve. We've already shown the two videos, right?
Correct. Yes.
Yeah. So, and the reason for the surgeon error, I call it surgeon error, but it's really more of a function of the patient. And the reason is the patient, some of these patients have, see, we're dealing with an inflammatory condition, okay? It's called arthritis. And it's the arthritis of the facet joint we're dealing with, okay? And we can't fix the arthritis, but the arthritis is a chronic process that goes on for years, and it builds up scar tissue and little bone spurs around the joint. Well, it's that scar tissue and bone spurs that make it the surgeon error, failure to destroy the pain nerve. Okay, and that's why RFA doesn't work, by the way. It's because there's too much scar tissue. Okay, shot. And when there's too much scar tissue, shot, you're never going to be able to burn through all that scar tissue. It's too thick. It's just way too thick. So I developed a system where we can burn through the scar tissue. It's much more powerful than an RFA. Shot. Just trying to get down to my last burn point, which is T1 shot. And his head is giving me a hard time. Shot. Hey. Shot. Any questions?
At this moment, no current questions.
Shot. Thanks, Henry. Did you look up Wolfman Jack? Shot.
I am currently.
Uh-huh.
One moment.
Let's maybe do another one. We're done with one side.
What do you think? I can clean it.
Clean it.
Yeah.
How's blood pressure? Good? Huh? I'm happy with it. I'm not getting any bleeding. Jordan, I move the floor a little bit to you. You have another one nearby in case we need it?
Yes, sir.
Oh, you have another one already on the field?
No, it's not.
Oh, okay, okay. Henry, where are we at?
I do recognize him, and funny enough that I actually recognize him from the movie American Graffiti when he played himself. That's how I remembered him.
Ah.
Yeah. American
Alright.
Graffiti, for people that don't know, is like, I think that was George Lucas's first movie before Star Wars.
Really?
Yes.
T1 7654. I didn't know George Lucas directed American Graffiti.
Oh, yeah.
Huh.
Written and directed in it, and produced by the director of The Godfather, Francis Ford Coppola.
Fascinating. All right, any questions from our audience?
At this moment, no current questions.
Shot? Okay, we're just getting in position to do our first burn. Shot? I'm trying to make my way down to the first burn site. And yes, I say burn because that's exactly what we're doing, folks. We are literally burning and cutting. It's a burn and a cut at the same time. Shot? Burn, cut, burn, cut. These pain nerves. That's the only way to get rid of them and get rid of the pain permanently is to cut the pain nerve. And that's what an RFA is supposed to do, but it doesn't do it. Shot?
No current questions, but we do have
Shot?
a comment from Rita on YouTube.
Rita.
Correct.
Hi, Rita. Shot?
Saying, well, since I can't get to you, I referred someone in Europe to you. I
Oh.
said, I think you can help. I said, get MRI. That sometimes you do Zoom and a visit to talk to the patient. They're getting the MRIs right now. They're in a lot of pain too and can hardly walk from pain like me.
I'm so sorry, Rita. I think the day will come that you will be able to come here. I don't know when, but I believe it because I want to believe it. Somebody will help you get here. So, Rita, don't give up. Keep the faith. One day, Jeff Bezos, Mark Zuckerberg, Bill Gates, one of them is going to pay for your surgery. We just need someone with money to stop spending it on themselves and help people that need help. Unreal, huh? All right, so what's happening? We're doing good. I'm not happy with his fascia. I've already mentioned it earlier. He has this really thick tissues in the back of his neck that are stopping my probe from going in. Let's get another one ready.
Can I have another one, please?
Huh?
Thank you.
Oh, under general is much easier, Sean. But even with that, the fact, the issue is not he's moving or anything. The issue is, no, some people have super thick dorsal fascia. And he's one of those people. Finally, I'm on the bone, right there. Shot? Yeah, that's a pretty good spot right there, actually. I'm finally on the bone. And I think part of the problem is not just the fascia, but also his spine is rotated. He's got a little scoliosis, so this side is actually, in my opinion, it's a little deeper. Shot? Deeper for me.
Ready.
All right, we're doing good. Any questions?
Yes, we have a question from John on YouTube.
Is this Big John?
No, this is another John. John R.
All right, hi John, welcome.
Asking, do you have a treatment for sciatica?
Yes, we do, John. So, John, the first thing you're going to want to do is know, why do I have sciatica? There are more than one cause, believe it or not. It's not always a pinched nerve in your back. The most common cause of sciatica is a pinched nerve in your back, in your spine. Most commonly L4-5, L5-S1, L3-4, in that order, from a herniated disc with associated stenosis. The second most common cause of sciatica is actually piriformis syndrome, spelled Piriformis, piriformis syndrome. And we can fix that as well. The third most common cause of sciatica is something faking something pretending to be sciatica but not really sciatica. In other words, ischial tuberosity tendonitis is a good example. It's where your attachment of your hamstring to your pelvic bone at the ischial tuberosity gets torn and inflamed and causes horrible pain in the back of your leg. And people think it's sciatica. It's not. It's actually ischial tuberosity tendonitis. Henry will write it down. And then another thing that commonly masquerades or causes quote-unquote sciatica is facet joint pain. And the facet joints are these small joints in the back of the spine, and that's what we're treating right now. And the arthritis pain in a facet joint can travel down your leg. As a matter of fact, can go all the way down to the knee. And people think that's sciatica, but it's not. It's facet joint pain. It's just referred. Shot? Yeah, it's just referred pain. So we can fix that as well. So the only one of those causes we cannot cure ourselves, it requires physical therapy, is ischial tuberosity tendonitis. But everything else we can cure with surgery here at Deuk Spine. Shot? All right, I got about 2 minutes left and we're done. What I can tell you is, on a scale of 1 to 10, for the amount of arthritis I'm experiencing and inflammation and soft tissue thickening is like a 9.5, so it's pretty bad. You can see the severe arthritis on the x-ray in the joints. Jordan showed it earlier. But look at the joint right above where I'm working here. Look at that sclerosis. It's all dark and all this bony overgrowth, right? That is exactly what I'm talking about. Arthritis. And arthritis causes tissue hypertrophy, enlargement. What happens is the tissues get bigger, thicker, harder. And when you go in there and you try to do this procedure that I'm doing right now, it's harder to do because the nerves are covered in all this thick scar tissue and they just don't burn well. Sometimes we have to come back and do it again. Hopefully we're not going to have to with this gentleman. I don't think we will, but I'm doing my best. That's why I'm taking my time to get it right. I don't want him coming back. I like to do it right the first time, but I can tell you right now, his is not an easy one because of all the scar tissue. Got 2 more areas to do and we're done. Shot? Any questions, Henry?
No current questions, but we do have a couple comments. This first one coming from John, once more on YouTube, saying that they have herniated disc in their lower back and neck, and they was hoping to have everything addressed when they come and see you. Yeah, John, so I don't know if you've done an MRI review or not, but the answer is yes, we can address everything, no doubt about it. If we're doing a neck and a back issue, typically we'll do one on, say, Tuesday and the other one on Thursday. It's like 2 days apart. He said that he had did the MRI review.
Oh, okay. Well, the point is, yes, we should be able to fix neck and back. There's a scheduler that should have reached out to you, Hopefully they did. And just coordinate with them. All right. At this point, I have really one more spot to do. And like I said, I'm just amazed at how thick his tissues are. I don't know why some people have thicker soft tissues than others. I think it's more genetically determined rather than environmentally determined. But getting down to his thoracic facet is, on my side was difficult. This side is equally challenging because of the angle of the approach to the scan. But we're going to get it done. I'm not worried about it. I'm just sharing my experience with you, kind of giving you the inside the surgeon's head. What's the surgeon thinking about? Kind of perspective. Any questions, Henry?
No current questions, but we do have a comment from Rita, once more on YouTube.
Rita?
Rita, correct.
Oh, hi, Rita.
Saying, I watched your 30 reasons for back pain. You are awesome. I'm in bed now, can't lift legs to cross over lately. Got worse to walk. So I'm trying to tell people to watch you and get to you. It's a dream, but if I got to you, I would need you and Dr. Davis. My knees are bad too, really bad.
Understood, understood. Well, we can definitely help you if you can get here. And we have the expertise to get rid of pain. So hopefully we'll see you soon. All right, I'm done with the Deuk plasma rhizotomy. We did 2 4mm incisions. Our patient will be flipped over, and we're going to do the Deuk laser disc repair from the front next. So go ahead and end the stream, and we'll be back shortly for the next part of his surgery.
Copy that.